Welcome to the Explainer. Today we're going to tackle a term that can sound pretty scary, a high-risk breast lesion. You hear those words and your mind just races, right? So let's clear the air and figure out what it actually means.
All right, let's put ourselves in that situation for a second. You've gone through a breast biopsy, you're waiting for the results, and then the phone rings. Your doctor says the result is high risk, but it's not cancer. So what on earth does that really mean? It's this gray area that we're going to break down today.
Okay, so before we get into the specifics, let's just define our terms. What even is a high-risk lesion? Why do doctors use this particular label? So it turns out there are 5 main types that pathologists are on the lookout for. We've got atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS, radial scar, and papilloma. Now, to be super clear, none of these are cancer, but they're like a yellow flag, a sign that we need to take a much closer look, which usually means some kind of follow-up procedure. Let's get into what each of these are.
All right, let's start with the first group. These are all about the cells themselves looking, well, a little weird. Pathologists call them atypical, and it basically comes down to what they see when they zoom way in with a microscope.
First on our list is atypical ductal hyperplasia, or ADH for short. You can think of it like this. Under the microscope, these cells are starting to look a lot like a very early non-invasive cancer called DCIS. But, and this is key, there just aren't enough of them to officially call it that. It's like it's on the verge, but it hasn't crossed the threshold. It's a precursor, a little heads up.
And this is why ADH gets that high-risk label. A needle biopsy, it just grabs a tiny little sample of tissue. It's not the whole story. What's wild is that when surgeons go in and remove the entire area where the ADH was found, about 30% of the time, they find that DCIS was actually there all along. The needle just missed it. So that ADH was literally just the tip of the iceberg.
Okay, let's talk about the lobular findings, ALH and LCIS. They're similar, right? Both involve these atypical cells, but this time they're in the lobules of the breast. So how do pathologists tell them apart? It actually comes down to something pretty simple. How crowded is it? With LCIS, the lobule is totally stuffed and stretched out with these abnormal cells. With ALH, there are some weird cells, but there's still plenty of room. It's not packed to the gills.
And here's why that little distinction is a really big deal. If you have ALH, your future risk of developing breast cancer goes up by about 4 to 6 times. That's significant. But if you have LCIS, that risk skyrockets to about 11 times higher. So you can see, even though they're related, LCIS is a much, much stronger warning sign.
And, just to make things more complicated, not all LCIS is the same. The source puts it kind of bluntly, a pleomorphic LCIS is badder than regular LCIS. Pleomorphic is just a fancy word meaning the cells look even more chaotic and disorganized than usual. And yeah, as you can guess, that's a more concerning version to find.
Okay, so we've talked a lot about what the cells look like. Now we're going to switch gears and talk about lesions that are defined by the structure of the breast tissue. It's not about the individual cells being atypical, but about the overall architecture being distorted.
So the first one in this category has a name that's, well, it's totally misleading. It's called a radial scar. But the first thing you have to know is that it's not a scar at all. It has zero to do with a past surgery or any kind of injury. So if it's not a scar, what is it? Well, picture this. A core of dense, fibrous tissue starts to form, and it's almost like it's pulling everything around it inwards. It tugs on the surrounding ducts, creating this distorted starburst pattern that pathologists can see. And that distortion, that architectural change, is the whole problem.
And here's the bottom line with a radial scar. It always has to be surgically removed. No exceptions. Why? Because that distorted, tangled up tissue is the perfect hiding spot for something worse. In fact, somewhere between 10 and 30% of the time, they find DCIS or even invasive cancer hiding in or right next to it. And it's also known to hang out with a specific type of cancer called tubular carcinoma.
All right, next up we have the papilloma. This is basically a little benign, wart-like growth that pops up inside one of the milk ducts. It's actually the most common thing to find growing inside a duct, and it has a very well-known claim to fame. It's the #1 cause of bloody nipple discharge.
And the classic, single papilloma follows a pretty predictable script. It usually shows up in women who are in their late reproductive or early menopausal years, think around age 50. And its favorite spot is right near the nipple. Now, you can have multiple papillomas, but when that happens, they tend to be scattered farther out, away from the center.
So those are the big 5 classic high-risk lesions. But
there are a couple of other interesting findings that pop up that are definitely worth a mention.
First, let's talk about something called a phyllodes tumor. These are pretty rare, but their defining feature is that they can grow really, really fast. We typically see them in women in their 40s and 50s, and while most of them are benign, there's always this worry, a risk of about 10 to 25%, that they could turn malignant, so you can bet they get watched very, very closely.
Okay, here's a scenario that sounds genuinely terrifying. Your imaging report comes back and it doesn't just show one mass, it shows multiple masses. Your immediate thought is probably, oh no, this has to be bad, right? But check this out. Here's a super surprising twist. If you have at least 3 of these masses, and, this is the crucial part, they are scattered across both breasts, it's often considered benign. I know, it sounds counterintuitive, but that bilateral pattern is key. If they're all in just one breast, this rule doesn't apply. And one last thing, lymphoma. It can show up in the breast, but there's a big difference depending on where it came from. Did it start in the breast? That's called primary lymphoma, and it's pretty rare. It usually looks like a single dense mass. Or did it spread to the breast from somewhere else? That's secondary lymphoma, and it's actually more common. But it looks totally different. Often there's no mass at all, just a kind of thickening and inflammation of the breast.
So we've gone through a whole list of these complicated-sounding findings. What's the one thing, the single most important message you should walk away with?
It really comes down to this. A needle biopsy is just a tiny snapshot. It gives you a hint, a clue, but it is not the full picture. For every single one of these high-risk lesions we've talked about, the rule is the same. The whole area needs to be surgically removed. It's the only way to know for sure what's going on and to make absolutely certain that something more serious isn't hiding just out of view of that initial needle.
So when you think about it, that high-risk result isn't really the final answer. It's not a dead end filled with uncertainty. It's actually the opposite. It's the very first step on a clear path to a final answer. So what does knowing this change for you? Hopefully, it turns a scary, confusing term into the start of a concrete plan. Thanks so much for watching.